Pediatric endocrinology course is actually something which has been quite close to Grow Society, and we've been doing that for quite some time. We actually started off initially with the programs which were there in terms of the initial workshops, which started way back in 2010. We conducted around workshops across the country. In 2011, we had the first practical pediatric endocrine course, and Dr. Raghupati, Dr. Chaurasia, and Dr. Rashmi Kapoor, all three of them were part of that inaugural program as well. Subsequent to that, we realized that doing programs at the level of individual places, we started doing PPECs across the country, was very labor intense and was very difficult to manage, and a lot of logistic issues. So we thought of using the social media, the YouTube and the Facebook platform to spread knowledge about pediatric endocrinology. And from there, we realized that while videos are going to help out, we need something more concrete in terms of more information which is available. We started with the round fellowship programs, but how many fellows can you accommodate? 2 or 4 in a given time. If you want more people to learn, the best way was to go online. And in 2018, 3 years ago exactly, on this very date, we started MedECLasses, which is a learning platform, and this has really evolved now with multiple other factors happening in the form of books and mobile application to make it much easy in terms of overall aspects. So over the last 11 years or so, we have conducted multiple programs across the country. Over 10 PPECs have been conducted. There have been over approximately 8 modules which have been involved and implemented in around 100 workshops across the country. So a lot of people have interacted and really find friends across the country in that regard, which has been really helpful in that perspective. So as discussed, we started off with our online learning program. And this e-learning started off with the number of videos which are now available over the YouTube. And on last count, there have been 700,000 views from those videos, watch time of around 40,000 hours. So there's a huge amount of pediatric endocrine repository which is available, which is being accessed across the world. But as I discussed, that this is more like a non-systematic way. We therefore went ahead and started with our learning.growsociety.in to provide pediatric endocrine learning using validated tools and practical assessment. And we have got multiple courses. Till now, we are on 24 courses available. We've got special courses for postgraduates and fellows providing specific needs using animated videos, lectures, and other information. We also conduct bi-weekly grand rounds. So every month we have got one for the postgraduates and one for the fellows. So it's free over Zoom. All of us should join. We already have around 700 people who are regular join these programs. And this is quite helpful from that perspective. As Sir was talking about, we had this basic pediatric endocrinology, and just recently, 3 months ago, we launched our advanced pediatric endocrinology, which is a 2-volume book related to every aspect of pediatric endocrinology. So entire course content is in these 1,000 pages, which are there in these 3 books. So these 1,000 pages, they're all online, as well as now we already made it offline as well, available for people. We always realize that the best way to practice is not really going through books, but to actually go from patient to the book and back. And therefore, we started developing these applications which make life much easier. So rather than going back and reading about DSD, you start off from the patient's point and then use that application approach pathway. So now the endocrinology app is by far the most resourceful endocrinology app on the web and the most downloaded one as well. It has got over 50 pathways, management, approach pathways, analytic tools. And over the next month, we're going to make a massive change in that, adding many new interpreters like puberty, DSD. So if you just put 4 inputs, you will get an output of DSD, output for puberty and obesity. I'm in pediatric endocrinology. This is a complete 3-year program, which is actually a hybrid program of both on-site and online over 4 weeks of visit, as well as online, as well as a diploma course in pediatric endocrinology for people who have got lesser time. Speakers, Dr. Riaz, who is a close friend of mine for the last 10-15 years. He is the associate professor in pediatrics at Government Medical College, Trivandrum. Dr. Modita Dhingra, eminent pediatric endocrinologist from Haryana in Kurukshetra, and Dr. Deepak Gupta, who was actually my junior at AIIMS when I was the senior resident, and he is now doing a very nice job in terms of the pediatric endocrine as well as pediatric practice in Janakpur, Nepal, as well as working in the Janki Medical College. We will also have Dr. Manoj, who will discuss about the few cases, but we'll start off basically with a few words about hypoglycemia. Now we know that glucose is the major source of energy, and the three most energy gulping organs in the body are the brain, the muscle, and the heart. Now glucose is the major source for all of this. There are alternate sources of energy which are also available, like ketones, which the brain can use. So if you have got less glucose, ketones will work. In conditions where ketones are also gone, the brain will have a severe damage. So if you have somebody who has hyperinsulinism, your ketones will be low. At the same level of hypoglycemia, let's say 30 milligrams per DL, they will be much worse off if we compare them to somebody who has got a glycogen storage disease in which the ketone levels are high. So ketosis is an important defense mechanism. In that regards, fatty acid is more for muscle and heart is not there for brain. We are mainly talking about brain because that's where the most glucose is used. Now, glucose homeostasis is very easy to understand if we consider it in the form of how we manage our finances. So we get money. So glucose is like money. We get the money, we take it, and then we tend to spend it maybe on the brain, some other functions, we are buying some things, and remaining, we start to deposit that in that perspective. And the most important bank that we are depositing is actually the liver. Now, liver is a readily available glucose source. You put the money in your savings account, you take it out. So it's like a very quick transaction. You just need an ATM or maybe a UPI or whatever, and you will get your glucose out. Now, if you have got too much of glucose, you will start storing in other places. You will go and store in the kidneys, which will basically be in the form of proteins. And from there, you will need to have glucogenolysis, gluconeogenesis to get that. And finally, too much glucose will go into your fat. And then finally, you will have it in your muscle. This is your last store in that regards. Now, in conditions where you are eating, you will basically store it, but when you are not, body will start giving you. So your first resource will be your ATM card, liver will give you out the money, and this glucose you can use. Now, once you exhaust that part, you will start acting at the level of the kidneys, wherein you will have the gluconeogenesis, which is going to happen. This happens typically around 12 hours and beyond. Glycogenolysis happens 6 hours and beyond. So anybody who is eating every 2 to 4 hours is not going to develop hypoglycemia because of this glycogen defects. And these defects typically present when the gap increases from around 6 hours. That is typically around 6 to 12 months of life. So if you have got a neonate with hypoglycemia and hepatomegaly, do not think a possibility of GST. It may be hyperinsulinism. It may be a real possibility of galactosemia. Secondly, the fructose defects will present later because now the gap will be like 12 hours and more. So they will present beyond 1 year of age. And after that, you have got compensation in the form of ketones. And finally, you will have compensation in the form of the muscles, which are the last to burn in that perspective. Now, we have got very important hormones which control that. We have got insulin, which is produced by the beta cells, which causes everything to decrease glucose, right from causing more synthesis to less release, to inhibiting gluconeogenesis, to inhibiting lipolysis, to inhibiting the ketogenesis. And then you have got 4 counter-regulatory hormones who have got different actions. We have got glucagon, which is going to cause glycogenolysis. So glucagon is always active if you have hypoglycemia. What it means is that if you have hypoglycemia and you give extra glucagon, there should be no response. But there could be one condition in which you will still have a glucagon response, and that would be, so if your insulin is high, glucagon will respond. So this is a diagnostic test for hyperinsulinism. You also have growth hormone, which is a lipolytic hormone, which will allow fat to burn. You also have got adrenal producing cortisol, which causes gluconeogenesis, and epinephrine, which causes glycogenolysis. So there are 4 hormones which are counteracting the effect of insulin, which means that if you have deficiency of one, you are not going to have hypoglycemia, and therefore there is a redundancy. You need to have a multiple hormone deficiency in which then only you will have hypoglycemia, while insulin excess will cause hypoglycemia immediately in that perspective. And this is very important to understand. So now when you are assessing a child with regards to hypoglycemia, you have to look at what will happen in the setting of hypoglycemia. The first thing which should happen is you shut down your insulin. Insulin should be 0 in a child who has got hypoglycemia. If you have a detectable insulin, that is significant. Number 2, cortisol and growth hormone should be maximal. So as we were discussing, if cortisol is less than 550, growth hormone is less than 10, it is inappropriately low for the context of hypoglycemia. Everybody with hypoglycemia should produce ketones unless there is high insulin, there is a fatty acid oxidation defect, or there is galactosemia. So ketones, we talked about phosphorus being most important in hypocalcemia, potassium being most important in hyponatremia, blood gas being most important in hypokalemia. Ketones is the most important investigation in the setting of hypoglycemia. So endocrinology is easy. Pick your one investigation, which will guide you, classify you in that perspective. So if you go now, hyperinsulinism means very high glucose requirement and low levels of ketones. Fatty acid oxidation defect would mean intermittent presentation, late onset, low ketones. GSD will present after 6 months of life, which will be a ketotic hypoglycemia with or without lactic acidosis. There will be hepatomegaly. Endocrine deficiency will cause ketotic hypoglycemia without lactate, while ketotic hypoglycemia is the diagnosis of exclusion. Organic acidemias are rare in that perspective. So if you now look at ketone is the key investigation. If you have hypoglycemia, ketone should be more than 2. And I am saying ketone, I mean blood ketone. That is better as compared to urine ketone. If ketone is less than 2, think of hyperinsulinism or a fatty acid oxidation defect, or rarely galactosemia. Lactate is high specifically in GSD1 and fructose 1,6 bisphosphatase deficiency. pH, as discussed, you will have acidosis in these 2 settings. Insulin, again, any detectable insulin means hyperinsulinism, and glucagon test will only be positive in the setting of hyperinsulinism. There is one more situation in which glucagon response test will have a role, that is in differentiating GSD1 from a gluconeogenic defect that basically happens in the setting of a fed state. So in a fed state, if you give glucagon, your acidosis will worsen in GSD1, it will improve in gluconeogenic defect in that regard. Now the approach, of course, is very clear. Look at ketones. If ketones are low, you're dealing with 3 conditions. Look at urine reducing substance, positive, galactosemia. Reducing substance negative, look at insulin. If it is undetectable, it is fatty acid oxidation defect. If it's detectable, it's hyperinsulinism. If ketosis is present, lactate will diagnose GSD1. If lactate is normal, go for organomegaly GSD3 and 6. And very importantly, measure growth hormone and cortisol before you diagnose ketotic hypoglycemia. So like we said, when you diagnose SIADS, do a cortisol and thyroid. When you diagnose accelerated starvation or ketotic hypoglycemia, do a GH and cortisol. So we'll now start off with right in the first case.
6-hour boy referred from the NICU. Patient having blood sugar of 36 milligram per deciliter. Dr. Riaz, what do you think? It is hypoglycemia or not?
In neonate with low sugar is always something very alarming to the neonatologist or the pediatrician. And we all know that there are a lot of controversies regarding what is hypoglycemia or what is low sugar in a neonate. And before going on for the actual cutoffs, we should be aware of the settings where we can have these low sugars. Babies who are having some insult at birth, like birth asphyxia, a baby already had some amount of intrauterine growth restriction, a baby who is born to a mother who was diabetic, a preterm baby. So such babies are taken as babies who are having risk factors. And when we look at the values, we know the operation thresholds, that is the points where we should act or where we should correct the hypoglycemia is actually related to the age of the baby in hours. So we can see that up to 2 hours or up to 3 hours, even 25 is enough. And from around 4 hours to the first day, it is actually less than 35 is considered as hypoglycemia. And above that, less than 50 is considered as hypoglycemia. And after 48 hours, we actually need to maintain the sugars more than 60. And when we say this, do all babies who are having this low sugars need a workup? No. These babies need action when they have a low sugar, but they need extensive workup if the hypoglycemia persists beyond 48 hours, or if the baby needs a high GAR. Usually we know the GAR will be somewhere near 8, but if we are seeing that it is rising, then we need to act. And I have enumerated some risk factors. If we see that these babies are having hypoglycemia without any of these risk factors, that means we need to find out what is happening. So these are the babies who we need a detailed workup.
Thank you, sir.
And so for this baby, there is no need of a detailed evaluation. This is a case of transitional hypoglycemia, which may improve by its own by feeding properly and encouraging the mother to continue the breastfeed, but keep a watch out for the persistence of the symptoms.
Thank you, sir, for guiding us. This is not hypoglycemia. Actually, we have to see for age what is the glucose value according to age. So our next case, 3-week-old boy presented with a seizure. Blood sugar was measured. That was 28 milligram per deciliter. We did genital examination showing micropenis. So Dr. Mudita, is it isolated hypoglycemia or anything we are missing in this case?
Yeah, good evening, everyone. See, so this is a 3-week-old boy with severe symptomatic hypoglycemia, and we have micropenis in the clinical presentation. Other details we need to see in the clinical picture is any other midline defect, for example, any presence of cleft palate, and eye examination also. So coming to the biochemical workup, at the time of hypoglycemia, which means during the critical sample collection, we first need to see the ketones level and blood ketones level. So here we can see that the ketones are present. It is 2.3. And next test which is relevant is the lactate level. So Dr. Manoj, the lactate is normal here, and we can see the sodium is lowish. It is 128 with normal potassium. So the next step, as per the approach pathway, we need to see is there any organomegaly?
No, there is no.
We do not have any organomegaly. And in the critical sample, later on the reports came out to be growth hormone of 4 nanogram per ml and serum cortisol of 125 nanomole per liter. So these are definitely low in the setting of stress, which is hypoglycemia. And therefore, we have two hormonal deficiencies, growth hormone and cortisol. So this is the case of multiple pituitary hormone deficiency. So moving on to the management of this case, we also need to look for other hormonal deficiency, for example, free T4 level and prolactin level, and manage accordingly. The first hormone to be replaced in this case will be hydrocortisone for cortisol deficiency. And if there is associated thyroid hormone deficiency, we need to add up Thyronorm a couple of days later. And the key message here would be any newborn presenting with micropenis with hypoglycemia, we should keep in mind the diagnosis of multiple pituitary hormone deficiency. And in this child, although the cortisol was normal as per the lab range, but when we interpret it as per the clinical condition or in the critical sample, it is definitely low. So this is a newborn baby with multiple pituitary hormone deficiency and managed correctly.
Thank you, ma'am.
So most of these babies will not require growth hormone in the initial newborn period, and later on we will be adding growth hormone.
Thank you, ma'am, for guiding us. It is not isolated hypoglycemia. It is due to the MPHD. Now, third case, we have 10-day-old girl presented with the hypoglycemia. Patient was on glucose infusion rate that was higher side, 40 milligram per kg per minute, and that was non-ketotic hypoglycemia. Ketone is 0.1 millimole per liter, and patient having reducing substance negative. So we are ruling out galactosemia in these cases. So Dr. Deepak sir, what is your opinion regarding this patient?
Okay, good evening, everyone. So may I know some bit of details about the history? What is the birth weight, gestation, any perinatal events?
Okay. Patient having normal birth weight.
Okay. Any other maternal problems like diabetes?
No family history of diabetes is there.
Okay. On examination, is the baby macrosomic or any hepatomegaly?
No,
Okay.
no, birth weight is normal.
Okay, so clearly we can see this infant this newborn is requiring very high glucose infusion rate along with low ketones. So straight away it points towards either this child is having hyperinsulinism or galactosemia or fatty acid oxidation defect. But galactosemia is very unlikely because urine reducing substance is negative. So probably we are dealing with hyperinsulinism. So we can do further investigation. The best will be bedside glucagon response tests. In that we can give 1 milligram per kg IM or subcutaneous glucagon and see the response. If the blood glucose rises more than 30 milligram per deciliter after 30 minutes, this confirms probably this child is having hyperinsulinism. So there are other. Yes, please go ahead.
What could be the criteria for diagnosis?
Okay, so basically any child who is having hypoglycemia, along with that, any detectable insulin or above insulin level more than 2 microunits per ml or C-peptide above 0.5 nanogram per ml, basically indicating high insulin or low ketones. Ideally, we should have ketone in any hypoglycemia, but in hyperinsulinism, because of the decrease in the fatty acid oxidation, ketone will be low and there will be high glycogen storage in the liver. So if you give the glucagon, there will be high glucose output from the liver. So there will be positive response. So any child, any neonate who is having hypoglycemia with high insulin, detectable insulin with positive glucagon response, so probably we are dealing with hyperinsulinism and we'll need further investigation to type the type of hyperinsulinism.
And key message from this case?
Okay, so any infant or newborn who is having hypoglycemia, there is no business of insulin to be there in the blood. If insulin is detectable, we are straight away dealing with hyperinsulinism other than galactosemia and rarely fatty oxidation defect.
Okay, thank you, sir. So we have another case, 6-day-old girl presented because of the hypoglycemia. Birth weight is 3.4 kg and ketone was negative 0.6 millimole per liter and GIR was high 12 milligram per kg per minutes, and we did reducing substance that was negative. Insulin detected 3, growth hormone is lower side 3 and cortisol is 120.
So I think this is a very, very common and interesting presentation, Dr. Riyaz. We have got a child with non-ketotic hypoglycemia, high GIR. Insulin is also detectable and cortisol is low. Now, the question that Dr. Manoj is asking is it hyperinsulinism or is it predominantly cortisol deficiency? That's the billion-dollar question here.
Yeah. This is a very, very interesting case scenario. Like we have a probably a baby with a higher side of weight and ketones are low. So these two are pointing, and high GAR, all these are pointing towards a hyperinsulinism. And we know that the reducing substance is negative, so that rules out galactosemia. So we are thinking that this could be a hyperinsulinism. But when we are looking down, we can see that the insulin is only 3. So is that 3 enough? So that is one question will comes to our mind. But any level of detectable insulin when there is hypoglycemia is abnormal. So we should take that message very clearly. When there is hypoglycemia, there should not be any insulin at all. So a detectable insulin directly points towards hyperinsulinism. But we are again confused. Our Mudida madam had already explained that when there is multiple pituitary hormone deficiency, there can be hypoglycemia. And you are seeing that the cortisol is low and GH is also low. So is it possible that way? But we should also know it is not a rule always. We usually expect a high cortisol in any child with hypoglycemia as a part of the stress response. We know the counter-regulatory hormone should be active when there is hypoglycemia. And if the hypoglycemia, if the cortisol is not rising, we should again think about a multiple pituitary hormone deficiency. But here, what happens is because of the continuous exhaustion, continuous hypoglycemia, there can be exhaustion of the adrenals and the cortisol can still remain low. And here comes the help of our glucagon response, because glucagon response is something very particular to our hyperinsulinism. If you are giving glucagon and you are getting a rise of 30 milligram of glucose, that gives us the answer that it is hyperinsulinism and nothing else. Next slide, please.
Yeah. So the key message, I think this was a very important message of exhaustion response which have happened. So Dr. Riaz, I think the key message is that high GIR is more important in this setting and cortisol exhaustion may happen in this regard. Very nicely put by Dr. Riaz here.
Thank you, sir. So we have another case, 2-day-old girl presented because of the seizure, and at that time blood glucose was lower side, 24 milligram per deciliter. It was a non-ketogenic hypoglycemia, ketone is 0.1, and reducing substance is negative. So galactosemia is out. Insulin was detectable, that was 6. And Dr. Mudita, how you will proceed for this case?
So as we can see, this is only a 2-day-old girl with severe symptomatic hypoglycemia and which is non-ketotic. So in this case, we need to ask detailed birth history and maternal history. So the first and foremost important thing is to ask the birth weight of the baby. So here, Dr. Manoj, can you specify the birth weight of the child?
Birth weight is 4.4 kg.
Okay, so this is an LGA baby. So in LGA baby with hypoketotic hypoglycemia with detectable insulin level, this is definitely a case of hyperinsulinemic hypoglycemia, but we need to look into the etiology in detail and ask for maternal details. So yes, we have come up here with maternal HbA1c, which is 8%. So the mother was diabetic and this baby has transient hypoglycemia because of being an infant of diabetic mother. So in this baby, we need to look for other complications in an IDM baby. For example, from endocrine perspective, we need to look for hypocalcemia, hypomagnesemia, and hypoglycemia. And we also need to look into other malformations. For example, the heart malformations, we'll do a 2D echo, and renal malformation, small left colon syndrome, and we will look for the neural tube effects. So comprehensive examination and detailed clinical history is very important in interpreting any baby with hypoglycemia. So this baby will probably not require any permanent treatment because this baby is an infant of diabetic mother with early onset of hypoglycemia and will probably improve within a week after birth.
Thank you, ma'am. So we have another case, 40-day-old child presented referred to us because of the patient having birth asphyxia, and patient admitted in ICU, and blood sugar was 28 and GIR requirement was high, that was 14 milligram per kg. Ketone was negative. Insulin is detectable at that time, that was 4.2, and child having birth weight is low, 1.6 kg. So Dr. Deepak sir, how you will proceed for this case?
Okay, again, this newborn is having investigation suggesting hyperinsulinism. Can you go back this? Can you please? Okay, again, this newborn is having high glucose requirement and low ketones along with detectable insulin. All these suggesting this child newborn is having hyperinsulinemia, but the point is the birth weight is only 1.6 kg. So some may wonder why this newborn who is having only birth weight of 1.6 kg should have hyperinsulinism. Generally, we think that hypoglycemia is because of the low store. So this newborn is having basically 3 hits. One hit is because he is SGA and is having low store. Second is he is having birth asphyxia, which can transiently lead to hyperinsulinism. And third, he is having I assume he is term baby, so he is a small for gestational age baby, which again itself can lead to prolonged hyperinsulinism. So all these 3 mechanisms can easily explain the hyperinsulinism is in this newborn. So can you tell me what is this child having, lactate and other things, any other issues?
Lactate was negative, sir.
Okay, so this child is this newborn is basically having hyperinsulinism, persistent hyperinsulinism because of the SGN, not because of the low store, because low store will explain hypoglycemia only within the 7 days. He is already around 14 days. So basically he is having hyperinsulinism because of the small for gestational age.
On follow-up, this child came after 2 weeks. Patient was on diazoxide 10 milligram per kg per minute, and we reduced GIR. Patient having complaint of weight gain and edema is there. So I want to ask to Dr. Riaz how you will manage this patient regarding the edema with diazoxides.
So we should all know that diazoxide can sometimes cause salt and water retention. And especially in newborns, it is always better to add with the diazoxide a dose of thiazide because that can avoid this fluid overload. And diazoxide also has other side effects like hypertrichosis, which is very common. We should alert the parents regarding the hypertrichosis because it will be very worrisome for them if you don't tell them initially. And it is always better if you continue diazoxide for longer time in children who are having persistent hyperinsulinism to look at uric acid levels, as well as to watch them for neutropenia, as well as thrombocytopenia. And furosemide should be avoided in this case. So the key messages in this case is this prolonged hyperinsulinism is very well known in SGA. Usually, we may be able to taper off diazoxide in a period of 3 to 4 months. But diazoxide for a short term will be very helpful in managing hypoglycemia in this cohort of children.
Okay, thank you, sir, for guiding us. We have another case, 15-day-old girl presented with the hypoglycemia. Birth weight is 3.2 kilogram, a high GIR requirement that was 14 milligram per kg per minute, and ketone was detectable 1.1 millimole per liter. Insulin is detectable 3.3. And Dr. Mudida, how you will evaluate this case?
Yeah, so this is a 2-week-old baby girl with hypoglycemia and a normal birth weight. The next more important point here is the GIR requirement. The GIR requirement in this baby is 14 mg per kg per minute, which is very high, and which suggests the diagnosis of hyperinsulinism. And also we have detectable serum insulin level in the critical sample. So this baby was started on what treatment, Dr. Manoj?
Diazoxide.
Yeah, so the response to the diazoxide was seen in this baby, and we also checked ammonia level, which gave us the diagnosis of hyperammonemia and hyperinsulinism syndrome, which is because of the mutation of glutamate dehydrogenase enzyme. And we can see here that these cases are usually mild cases of hyperinsulinism. And we also must keep into mind that the serum insulin level does not guide us that this is the case of mild or severe hyperinsulinism. Any detectable insulin will give us the diagnosis of hyperinsulinism. And it is the response to drug which gives us the diagnosis that it is a mild case or severe case. So diazoxide response is the key in these cases, and usually they do well. And it is also important to measure ammonia level in the milder forms because it will guide us in the genetic tests.
Let's move to the another case. We have 6-month-old boy presented with the lethargy, and blood sugar was 36 milligram per deciliter. Dr. Deepak sir, will you guide for this patient?
Okay, so can you briefly mention whether this is the first episode or this is the recurrent, whether this occurs only in the early morning or it occurs any time of the day? Can
Yes,
you please
this
explain?
is the first episode. There is no significant NICU history. There is no neonatal hypoglycemia.
It occurs any time of the day.
Okay, so basically now we are dealing with post-neonatal hypoglycemia. So any hypoglycemia which occurs during or after the neonatal period is significant. We should not neglect, though during this age X-related fasting could present, but we should work up this child to find out what is the cause. So can you tell me what is the ketone level so that we can proceed further?
Ketone is 2.4.
Okay, so So basically now we are dealing with ketotic hypoglycemia. So what is the next lactate level?
We did lactate, that was 10, higher side.
Oh, okay. So now we are dealing with ketotic hypoglycemia with hyperlactatemia. So what is the appearance of the child? Any organomegaly, any cherubic facies?
On examination, child having hepatomegaly is there.
Okay, so this straight away points us towards either this child is having GSD or fructose 1,6-bisphosphate deficiency.
So what will be the key message regarding this case?
So any child who presents after the neonatal period should be taken seriously, and all efforts should be taken to rule out organic cause before we label this child as having idiopathic ketotic hypoglycemia. And particularly if there is hepatomegaly, moon-like facies, we should not miss that.
Thank you, sir. We have another case, 3-week-old boy presented because of the failure to thrive. Blood glucose is 30 milligram per deciliter. GIR requirement is 6. Patient having hepatomegaly. So, Dr. Riaz, sir, how you will evaluate this patient?
Yes, for any pediatrician, when such a baby is coming, our diagnosis is a failure to thrive, and it can be due to a feeding problem. That is what we think of first. And whenever we see hepatomegaly also, we think that in malnutrition also hepatomegaly can be there. But it is always better to do a ketone level when we are seeing a hypoglycemic baby, even though it is part of a malnutrition or a failure to thrive. And also to do basic screens, like just doing a reducing substance. Here we are having an answer because reducing substance is positive in this case. So from our algorithm, it goes to the ketones are actually low, and when ketones are low, there are only 2 or 3 DDs we have, and when the reducing substance is positive, we directly go for galactosemia. So galactosemia is something which is worth understanding or worth finding out early in life, because we can substitute the diet and we can have a better life for the baby. Otherwise, it can be very devastating. Here, the hepatomegaly is one clue, and reducing substance, the presence of reducing substance is the next clue. And as we know, if we feed these babies with lactose again and again, the hepatomegaly will increase, the failure to thrive will become more severe, there can be cataract, jaundice, and eventually the baby will lose its life. So identifying a galactosemia from this hypoglycemia is very, very important. Thank you.
Thanks. So one patient referred from the pediatrician with a child having 1 year of age, and patient is not able to walk in the morning. Blood sugar is lower side, 24 milligram per deciliter. There is no any hepatosplenomegaly. So Dr. Mudita ma'am, what you will think about this patient?
So this child is presenting at 1 year of age. So at this age, usually the gap of feeds is increased from around 8 to 12 hours. As you have already mentioned that the child does not have any hepatomegaly. So the glycogen storage disorders are ruled out. So the next key investigations are the ketones and the lactate. So here we can see ketones are present and the lactate level is normal. And there is no organomegaly as already mentioned. So in the critical sample, as we can see here, there is appropriate response to growth hormone and cortisol. So cortisol is more than 550 nanomole per liter and growth hormone level is more than 10 nanogram per ml. So this is probably a case of accelerated starvation, which is usually seen in children who are SGA at birth and thin and lean children. So usually they present with the symptomatic hypoglycemia in the morning hours when the fasting is prolonged and around 1 to 5 years of age. Usually it recovers at around 5 to 9 years of age automatically, and the only treatment which is required is supplementation of extra snack given at night time and avoiding prolonged fasting. So we also need to keep in mind that accelerated starvation is the diagnosis of exclusion. So all the investigations have to be done before labeling the child with accelerated starvation. And yes, as we have mentioned here, that the key message here is that the child had ketosis with normal lactate, and we have already excluded growth hormone and cortisol deficiency in this child.
Thank you, ma'am, for your outputs. Our last case, 2-year-old boy presented because of the failure to thrive. Patient having vomiting, lethargy, and RBS is 28 milligram. Ketone was detectable 3.2 and lactate was normal 1 millimole per liter. Patient having accelerated starvation. So, Dr. Deepak, how you will proceed for this
Deepak, do you
patient?
agree that this is also ketotic hypoglycemia in this case, or there's some confusion here?
Sir, there is some confusion because this child is having very low blood sugar and there is ketosis. But before labeling accelerated starvation, we should do the thorough history, physical examination, and investigation to label this child. As we did the examination in this child, we found that there was some pigmentation and cortisol was very low. That was 150 only. So if we label accelerated starvation without doing investigation, we'll miss this important diagnosis and child will die in near future. So before labeling any child who is having accelerated starvation, we should do thorough history, physical examination, and investigation.
So what will be the key message regarding these cases?
So before labeling any child who is having ketotic hypoglycemia as accelerated starvation, we'll miss many important causes, particularly endocrinopathies and milder form of GSD. So we should do the thorough investigation before labeling any child who is having ketotic hypoglycemia as accelerated starvation.